Mm-hmm. Okay, so no one got worse. That's a good thing. I was really happy with the results. What I'm going to show you first is just a summary of everyone. And the prize goes to the person whose AHI went down by 98.65%. Their AHI went down from 22.2 to 0.3. And then I'm going to show you a graph. First I want to see if I can get my mouse to work. There's a gremlin up here somewhere. I think I'll be okay. Yeah, there we go. Okay, so here in this person, just to summarize, I'll show you the graph. So that's the numbers right there. We did 14 studies last night. We did 15 the night before. One person did not wear their Medibyte last night. Okay, if we look at this graph, the blue here is the baseline Friday night, and next to it would be the person's Saturday night test. So I've kind of ranked them here in order from most severe to kind of mildest on the first night. So on this one here, we went from 46.4 to 31. This person went from 29 to 8. This person went from 22 to 0.3, so that's quite a drop. You see it down here. Now the next person, 19.8 to 18.3. We'll take a little closer look at the reports on these. 17.1 to 6.2, from here to here. The next one from 13.3 to 6.5. 12.9 to 6.2. 10.4, that's this one, 10.4 to 3.7. 7.1 to 4.3. 6.6 to 2.5. 6.5 to 6.3. 3.5 to 2. So that's interesting, even in someone who you would never make an oral appliance, unless there was a complaint of snoring, of course, but not for AHI, still managed to get an improvement. We'll take a closer look at that. And then this one's interesting, 2.8 to 2.8. But as we've been saying this weekend, it's not all about AHI, so I'll bring that one out in more detail later, and we'll take a look at some of the other parameters where you can still see improvement. Now this one here was interesting. Even though it went up, it's because the person was wearing CPAP on the first night, and on the second night, just the oral appliance. So it still came out at 5.4, which is borderline within normal limits, at the very low end of mild. But again, those are arbitrary numbers, right? What makes the body say it's 4? Someone with an AHI of 4 can feel just as sleepy as someone else with an AHI of 6. So let's take a look at the reports. Here's the one from 22.2 to 0.3. And you'll also notice that the RDI went from 28.8 down to 0.6. Can you see that okay in the back? Now if we scroll down, take a look at the SpO2. So on the left, this is the baseline night, no appliance, and on the right is the follow-up night with the appliance. And you have to appreciate this is kind of technically risky for us because there's all sorts of things that can happen. You know, I think 1 or 2 people perhaps out of the group where the appliance didn't fit. So I'm not familiar really with any other courses that have done this historically where you've done the baseline night and a Friday night and the follow-up on a Saturday. Typically you wouldn't do that. You'd wait at least 3 to 4 weeks between your baseline and your follow-up. So let's take a closer look at the data. On the pulse ox table, the baseline was 90 to 100% SpO2 for 99.5% of the night. So we're really hitting a ceiling effect there because you can't really go much above 99.5. But we managed to move it up to 100% on the second night with the appliance in place. And if we take a look, remember I said the mode on night 1 was the group 96 to 98%, and that was almost 74%. But that number went up to 84% on night 2. And in fact, between 98 and 100% oxygen level, we went from 11.3 to 14. So the blood oxygen level went up. The amount of time below 88% went from 1.7 minutes down to 0. So that's great. That's really good. So the blood oxygen levels improved. The number of desaturations on the baseline night of 4% or more, the clinically significant drops in blood oxygen level went from 63 occurrences to 1. So that's fantastic improvement. So from 63 we went to 1. But you'll notice what I said earlier where I mentioned about the, I would not analyze the mean SpO2. If you take a look here, the mean SpO2 here is 96.3. The mean here is 96.7. That doesn't really show you much improvement. And that's why I would rather look at the minimum. See the minimum? 84 to 90, what's that say, 93. That's a big improvement. So the lowest blood oxygen level on the baseline night was 84, but with the appliance in place, the lowest it went down to was 93. So that's the number that should have been analyzed in the data that Alan gave to, what was it, Rush?
Yes.
That's why you don't want to use grad students.
I use what I can get.
I know. I would have done it for you. I did analyze some data for you, though, didn't I?
We did. Got it published, and it's in your handout, in your flash drive.
So let's take a look at night 2. Sorry, the second page. Sorry. Take a look at the second page, night 1 versus night 2. So what's interesting here, the supine AHI, 45.5. 41% of the night, still slept almost 24% of the night, almost a quarter of the night on their back, but their AHI was 1.3. Let's take a look at the snoring volume table. So you see here we had 0.1% between 80 and 90, and that stayed the same. But the 1.1% between 70 and 80 went down to 0.4. 60 to 70 on the baseline night was 4.6, now went down to 1.6. But we had a big jump in the lowest range between 40 and 50 from 36 up to 62. But it's interesting that the mean score from 66 went to 67. So I really don't look at the means as much as I look at trends and movements in the modes. The other interesting thing here I wanted to point out was the flow-limited breaths, the number of flow-limited breaths, the percentage from 34% to 10.6. So if we're looking for indications of upper airway resistance syndrome and flow limitation, the real mild forms of sleep disorder breathing, we see a dramatic improvement from about a third of the breaths that occurred were flow limited. That went down to about a tenth, or 10%. And if we look at a graphical representation of the snoring, I think that jumps out at you as well, although according to Alan, the FDA was not able to interpret that.
A question. If a person's mouth is closed, can they still snore?
Yes.
They can.
Yes. Huh? I'm not asleep. That's right.
It's a little more challenging to do that, but certainly you can. So this gives you a good summary right here. What I really like to look at is the trend on the SpO2. You see here how you have desaturations, desaturations, desaturations. This is completely flat. I mean, that's a huge improvement.
That's a good flat.
That's a perfect flat, yeah. That's the good flat. You don't want the flat on the airflow, but you do want it on the SpO2. Any questions about this? Okay, we'll bring up another one. Now this person went from 13.3 to 6.5. The RDI went from 20 to 10. And we'll take a look at the SpO2. So we had 1.5% of the night between 80 and 89%. And with the oral appliance in place, that was 0. So even though we had 98.5% of the night between 90 and 100% blood oxygen level, that went up to 100%. And down here we had 3 minutes of the night, less than 88% SpO2, and that went to 0. Number of desaturations, clinically significant desaturations, went from 62 to 7. Also interesting here is we had a drop in the heart rate. So 16.1% of the night, the pulse rate was between 75 and 100 beats per minute. And then it moved down, so we had an increase between 50 and 75. So the heart slowed down. 84% of the night was between 50 and 75, and on the second night it was 92.4%. So that moved in a direction we want to move in because it means less arousal.
Look at the time. The time went from 80 minutes to, what does that say,
24.
24, yeah. That's rather dramatic.
Yeah, I think the total recording time was shorter on the second night for this person.
A point about that, because that is my scores up there. I was really fearful of using this appliance because I'm a big-time mouth breather, and I can't even tolerate a conventional night guard. And so I waited until about 1 o'clock. so that I'd be.
Did you gag?
No.
Do you know if you mouth breathed? Do you think you did?
I'm not sure. Every time I was awake, I purposed not to.
Okay. So let's pull that over and look at breaths per minute and see what we can see. $13.
13.49 versus 13.62.
Okay. If you weren't mouth breathing the night before, you're probably not mouth breathing.
Do you feel any different?
Yeah, even though I got, how many hours of sleep? I mean, it was like 5 at the most. I woke up fairly refreshed. And I have a question. Wearing your device, does that allow a person to sleep fewer hours because they're getting better sleep?
Typically what we're seeing is they're sleeping more and enjoying it more. Pardon? Mic's on.
That's a good endorsement. Any questions on this? Okay, I'll move to the next one.
See, again, the snoring was a huge improvement. And so, what is going to happen is that as those tissues heal, that will get even better. But for one night to cut it out, that's very impressive.
Now, in this particular instance, we went from 7.1 to 4.3. Now, what I wanted to show here was we did hit the ceiling right here at 100% blood oxygen between 90 and 100%. Still stayed at 100%, but we are spending more time above 96%. So here we're about 94% of the night, and over here I think we're, 87, 96. Number of desaturations went from 19 to 100.
19 to 10.
Sorry, thank you. That would be bad going to 100. Scratch that, cut that off the video. 19 to 10. Now, what's interesting on the second night is we actually had more supine sleep. So from 76%, we went up to 93% of the night, and the apnea-hypopnea index went from 9.2 to 4.2.
Well, it also was positional before.
I think that's all I want to mention about that one. Any questions? Okay, this one's interesting because it stays the same as far as the AHI is concerned. The RDI also stays about the same, 5.7 to 6.0. So the number of desaturations went from 10 to 8. The breaths per minute stayed at 15.3 to 15. The mean snoring, 65.7 to 64.8. The snoring did drop a bit. 93.5% of the night between 40 and 50 went up to 97. But again, this usually is not a person that you would normally make an oral appliance for. But when you see cases like that, take a closer look at some of the numbers that are involving the closer examination of the blood oxygen. For example, in this area right here, and the AHI, the apnea-hypopnea index by body position, stayed roughly the same. 3.2 supine on the baseline night went down to 2. Non-supine 2.6 went to 3. Any questions? Well, those are often associated with body position changes, or even if you flex your wrist, your fist, you make a fist. And it's often what happens on the software to tell you if you have mild perfusion or low perfusion. So the quality of the light signal going through the finger. So that drop normally takes, it's like 2 or 3 seconds, and it drops from whatever it was down to maybe 0 or less than 50. And if the quality of the signal goes poor and it drops down, the software automatically marks that and tells the program to omit it from statistical calculations. As Alan mentioned yesterday, the better you put the finger probe on, the better quality you get on the recording. Okay, here's another case from 46.4 to 31. Now, normally, if you follow the American Academy of Sleep Medicine guidelines, according to their rules, what would you do first with someone with an AHI of 46? Would it be an oral appliance or CPAP? CPAP, right. There are cases, though, and Alan showed you those earlier, where you can see dramatic improvements even in severe OSA patients. So this is only in one night, mind you, and normally you'd want to wait 3 or 4 weeks for a follow-up. So there's a good chance this number is even going to go down further when you reduce the inflammation over the next few weeks. Also, this person might want to consider combining the CPAP with oral appliance. But at a minimum, repeat the test in 3 to 4 weeks and then make an informed decision at that point. So let's take a closer look at this data. So here we have 358 desaturations of 4% or more on the baseline night, and on night 2, 247. If we take these lasers, or use this laser. If we take a closer look here, the mode is 33% of the night between 92 and 94%. And on night 2, the mode actually is 94 to 96%. So it went from 12.1% of the night between 94 and 96% blood oxygen. That went up on night 2 to 35%. If we look also on night 1, only 2% of the night was between 96 to 98%. And on night 2, it was 10.8. So that's why I like to look a little more closely, because if you just look at the grouping 90 to 100%, particularly for people with mild and moderate sleep apnea, you're not going to get as much information out of that large grouping of between 90 and 100%. That's why it's good to look at those 2% increments, because you want to move their blood oxygen level up. And again, on the mean, it's not a profound change, right? 91.1 only went to 93. But if we look at the minimum, it's interesting, we look at the minimum SpO2, 79, there was still a drop to 76. But overall, profound improvement because there's a dramatic drop in the number of clinically significant desaturations. Time spent below 88% went from 7.4% of the night, which was 33 minutes. That went down to 4% of the night, which became almost 20 minutes. So that's a good drop as well. If we take a look at the pulse rate table, you'll see a dramatic slowing in the heart rate. Almost 77% of the night on the baseline was between 75 to 100 beats per minute. And on night 2, that dropped to 39%. And we went from, in the grouping of 50 to 75, went from 22% up to almost 61%. So that's another good indication we have fewer arousals going on. So everything was heading in the right direction. Let's take a look at the snoring volume. Why do you think that went up?
Too much wine.
Too much wine. That's definitely a possibility. Also, it could be because we opened up the airway and gave more opportunity for vibration in the tissue.
I had my mouth taped shut last night, and I didn't expect that, but I did wake up this morning with a throat that was mildly sore. I didn't understand that.
Well, do you want to comment on that?
No. No, I can't comment on that. Why, I wouldn't have expected that, certainly.
And then make another decision from there, whether you titrate or you go to an adjunctive therapy and add something else to it, like CPAP. Let's take a look at the...
I have a question.
excuse
I have a
me.
question.
Okay, can I just make a comment? I would say that at this point, I don't know why if you're comfortable this morning, I wouldn't hesitate to adjust it 2-3 turns, because I don't see a reason not to at this point. If you feel it's uncomfortable, then yeah, then I would do 2-3 turns and see what happens. But you got to be able to test eventually. Yeah, okay.
I have a question. The percent flow breaths, now, what is that number exactly?
Flow limited breaths?
Because his went from 40 to 67. What is that significance?
This number versus that number?
Yeah.
Yeah, so the number, remember I mentioned earlier why the snoring went
It
up?
was 15.2.
Even if you look at the snoring here,
16.6, that's fine. Yeah.
the snoring, and you look at it graphically, there's more snoring on the second night. And what I offer as an explanation for that is because they have the person's wearing the oral appliance, opens up the airway. We've already seen there's an improvement in blood oxygen, there's a reduction in apneas and hypopneas, so there's more opening in the upper airway, which means there's more opportunity for vibration of the tissue during the respiratory cycle. So what we're picking up then is an increase in the number of breaths that are flow limited and an increase in the snoring events.
Could that be because his mouth was taped shut or not?
No, it's probably because the airway before was collapsing more, so there was less opportunity for vibration.
Okay.
And because of that, fewer of the breaths actually came up as flow limited.
Okay.
Yes?
Is it possible to hear the difference in sound
Yep.
of the snoring with the Moses in?
Let's try that. It's a good question. I haven't listened yet myself. I'll just bring up the studies and we'll pick a spot and play it back. So this is the first night. So this looks like a good spot right around here. And I'll play it from here. So that's inspiratory and that's expiratory. See if there's one with a good arousal on awakening. Probably this one. You can hear the difference once the arousal or the awakening occurs. This is during the event. So I'll go to the second night. And this looks like a good spot right here. It looks different. Sounds like more flutter.
That's quite a sound for a mouth tape shot.
It's interesting on the where there are respiratory disturbances, we seem to have more inspiratory and expiratory. Yep, both ways.
Try that area at the front, the second hour with the desats. Those are some powerful desats there.
Yeah. So let's see.
Nothing.
So there's very little flow here. It's very flat. Any questions before I move on? Yes?
Under the pulse category, because you see 125 to 150, 100 to 125, 75 to 100, and so on. What would be considered typical ranges that we would like to see as far as percentages for each of those breakdowns?
Well, none of these, typically you'd want to be below 100, right? You don't want to see tachycardia. In a severe sleep apneic, you'll often find bradykardia. So during the event, the heart rate would often slow down to below 60. And then with the arousal associated with the termination of the respiratory event, they'll often become tachycardic for several seconds. So what you want to do is ideally you want to get nothing up here. You know, anything above 100, you don't want to see anything up there. Now, if you have a marathon runner, a lot of times these people are chronic bradycardia, so you'll end up with 99% or 98% between 50 and 75. So it really depends on the health of the patient. So usually the more severe the sleep apnea, you know, we know that people with an AHI above 30 are at greater risk for all sorts of cardiovascular consequences, hypertension, stroke, and so on. And in severe cases, you'll often see people with cardiac arrhythmias during sleep. So, you know, premature ventricular contractions, and then there are multifocal PVCs, and then, of course, the people with not sinus arrhythmia, what my father-in-law had, what was that? Atrial fibrillation, thank you. If you have AFib patients, then this chart will often be off. It won't be working properly because the pulse ox often has trouble even picking it up correctly, so the pulse rate may or may not be inaccurate with some of these cardiac arrhythmias. So this next person here went from 29 to 8. So would you consider that successful? Yes. In a number of different definitions. The RDI went from 33 to 15.8. If we scroll down and take a closer look at the pulse ox table, see some dramatic improvements there. We went from 159 clinically significant desaturations all the way down to 33. That's fantastic. Now let me just scroll over a little bit to the left on night 2. And if we take a look at this, we are at 90.9% of the night between 90 and 100% blood oxygen level. And that went up to 99%. The time spent below 90%, so the time between 80 and 89% blood oxygen level on night 1 was 9.1%. That went down to 1%. That's fantastic. The total time below 88% went from 3.2% of the night, or 11 and a half minutes. That went down on night 2 to 0.2% of the night, or in other words, 0.7 minutes to less than a minute. So that's great. Good improvement in blood oxygen level. But let's take a look at the mean. The mean SpO2 only went from 92.3 to 92.5. And again, that's why I would not analyze the mean. But the minimum went from 80 to 85. So that's another good indication. Any questions on any of that? And also at the same time, you'll see a further slowing in the heart rate. 52% of the night here. Oh, I'm sorry, I went the other way. That went up, in fact. But it's still below 100, so we're in good shape there. Let's take a look at the snoring volume. And again, it went up a little bit, but only at the end. So here's the only real loud snoring. So what I would do in this case, this is a good example of why I would go back to the raw data and take a look. So the mean volume here is actually up, but all the snoring occurs. If I take a closer look at the snoring volume, it all occurs at the very tail end of the night, right here. So let's scroll down and see if there's anything in the body position. So the body position did not change at that point, because the body position changed here. And that occurs roughly about 30 minutes or so before the snoring occurs. So that's a good example of why I would go back to the raw data and actually listen to it.
Rem sleep there.
Could be. It could be REM sleep, certainly. Oh, you did? Okay. So that likely is something associated then. It could be a sleep stage change. Oh, good. See? There you go. Fantastic. Take a look at the AHI by body position. So on night 1, 99.9% of the night non-supine, and on night 2, 100%. So there's no difference between the body position. So we know that was not a confounding variable between night 1 and night 2. However, the AHI dropped from 29.3 to 8. And again, that should improve even further over the coming weeks with a further reduction in tissue inflammation. Breaths per minute actually went up a little bit from 17 to 19. Percentage of flow-limited breaths from 19.9 down to 13, 13.6. And percentage of flow-limited breaths or snoring sounds went from 42.4 down to 16.7. So that's a really good indication that we've had a further reduction in any type of mild sleep-disordered breathing. And if you look graphically, you can really see a nice improvement in blood oxygenation. Look at the desaturations here, here, and here, compared to the dramatic improvements on this side on the second night with the Moses appliance in place. Any questions?
We can do about one more.
One more, that's it. And Joe, maybe you could comment. This is what, your third or fourth Medibyte test? Because we did a test on you originally here in Chicago back in March. And you came out at 17.1. 17.3. So that's remarkable. So in March when we did the recording, he was 17.3. Now he came out at 17.1 on Friday. And you've tried other appliances, right, in the past? And so with the EMA in your past test, what was your AHI? 8.9. Okay, so here we got him to 6.2. That's fantastic improvement. Let's take a look at the blood oxygenation levels. From 76 occurrences of clinically significant desaturations on the baseline night, that went down to 44. 97.7% of the night between 90 and 100% SpO2, that went up to 99.5. 2.3% of the night, or 8 minutes, between 80 and 89%, that went down to 0.4% of the night, which is 1.7 minutes. We'll take a look at the snoring. Look at the graph. That's remarkable. If you just look graphically at the drop in snoring intensity, this is from the snore microphone, night 1 to night 2. If we go look in further detail at the snoring table, the range, 90 to 100 dBs was 0 to 0. From 80 to 90 decibels, we went from 3.4% of the night to 0. From 70 to 80 decibels, from 6.5% of the night here to 0.4. 60 to 70 decibels, from 11.4% of the night down to 3.1. 50 to 60 dBs, from 50.5, that went down to 33.5. And 40 to 50 went from 28.2% of the night up, which is what you want, went up to almost 63%. So the average snoring decibel level went from 70.6 down to 65. So that's a fantastic drop in snoring intensity.
Did you get Joe?
The other thing I want to point out here is on the flow-limited breaths, right here. Percentage of flow-limited breaths from 26% down to 7.4. Percentage of flow-limited breaths or snoring sounds from 75 down to 21.5. So that's definitely a successful case as well. Any questions on that? Great. I think we're done now.
Thank you.
Thank you.